This one. All righty. So here we are in week 7 of our OASIS education. The good news is that means there's only one more week after this. With this presentation today, we're going to be going over section N as in Nancy, and you'll see it has the meds. And with that, hang on, I got to turn the heater off in my room here. It's starting to swelter a little bit. So with that, as you see when we get into the item, there's some new challenges that come through with the meds as far as the drug classes that they are in. And depending on the EMR, it might or might not be telling you what classification they're in. So what I've also developed is obviously a cheat sheet for those classifications, and the coding only group is getting their training next Tuesday. So after I do that training, then I will issue this tool because we don't need it, remember, until OASIS E begins, which is potentially December 27th, depending on when that Moon 90 date is set for. So December 27th is theoretically the go live date for OASIS E, but it all depends on that Moon 90 date. So that said, let's get into section N. Get the right mouse. That would be helpful. All right, so we know it all starts with med reconciliation, and we could tell just from those A items that were in the administrative section about, if someone is transferred, is the information going to the provider or is it going to the patient? So this med reconciliation is becoming even more and more important about, making sure these meds are tracked along with the patient and has all the appropriate information on it. So the clinicians have to have that, the most accurate list possible of everything they're taking or supposed to be taking. They might have 20 meds on their list and they're only taking 5 of them for whatever the reason might be. But if they have 20 medications prescribed and hanging around the house, they have to be in the list. So they should have the drug name, the dosage, the frequency, and the route. The clinician should be identifying which ones are new, which are changed, or which are longstanding, because that also helps to give us an indication of, where should that plan of care be going towards? Look at those new meds. Is the patient good with handling those meds, or they just look at them and go, yeah, I have no idea why I'm taking that? Or like tapering prednisones, when I'm supposed to be taking that. And hopefully the clinicians are comparing that list against the physician's admission, transfer, or discharge orders to ensure that the patient is taking the correct meds at all transition points in care, right? Which is basically anytime a comprehensive assessment is required, we should definitely be doing med reconciliation, we meaning clinicians. But of course, anytime a new med is introduced in the home, they should also be doing med reconciliation. So it really is an ongoing process from day one on. It's not a one and done thing. So the first item we come to in section N is this new one, N0415, high risk drug classes. And as you can see, it's a 2-column item. The stuff on the left says high risk drug classes, use and indication. So for those 2 columns on the right, column 1 says is taking, and column 2 says indication noted. So for is taking, what they're looking at is the clinicians to check if the patient is taking any medications by its pharmacological classification, not how it's used in the following classes listed. So for example, I put down there, follow the blue lines here. If the patient's taking aspirin so that his blood remains thinner, so it's basically being used as an anticoagulant, aspirin's drug class is an NSAID. So we're not going to be checking off E1, which row E is an anticoagulant. So he's not taking an anticoagulant, he's taking an NSAID. So it's there should be checking them off by the pharmacological classification, not its actual use. All right. Column 2, indication noted, says if column 1 is checked, check if there's an indication noted for all meds in the drug class. So if something is checked off in column 1, say, yep, they're taking that. Is there something in the documentation that indicates they should be taking that? Right? Because sometimes we get out there and we're looking at the meds like, why do you have this? and we can find nothing in the paperwork to indicate why they have it. And they just look at it and say, oh, that's from 3 years ago. And you look at the date, yeah, it's from 3 years ago. I'm still taking it. Like, no, you should not be taking this. All right. The other caveat to that indication noted is, let's say they have two, like in this example, we're on row F for the antibiotic. They have two antibiotics in the home. Only one of them is noted by the provider for the patient to be taking. F2, that indication noted column then is not checked because you didn't fulfill all the requirements. So all of the antibiotics have to be indicated by the provider that they should be taking these. So that's really, that's going to be interesting to see if everyone keeps on top of that guidance. So what we're looking at specifically, and this is where that cheat sheet will come in, is antipsychotics, anticoagulants, antibiotics, opioids, antiplatelets, and hypoglycemics, including insulin. What it does not include is your non-injectable insulins, okay? Or actually non-injectable, they're actually non-insulin anti-diabetic meds. So they are not included in that J. So that's your, Victozas and stuff like that, right? And then of course there's Z, none of the above. You could have a patient that has none of those above classes that they're taking. So long-acting medications that are given every few weeks or monthly are counted only if they're part of the current drug regimen at the time of the assessment. We want to be sure that they're including newly prescribed meds that are part of the current drug regimen, even if that med is not in the home yet or the first dose hasn't been taken. So, we know the guidance changed in January as far as the meds aren't in the home yet. How do we, answer these items? Well, we know, we'll just pretend and, can you tell how they do with adjusting, taking the meds and all that? Herbal and alternative med products are considered to be dietary supplements by the FDA, so they're not counted as medications. So even though someone might get stoned out taking something, no, it is not an opiate. All right. N0415E, the anticoagulant, this does not include antiplatelet meds such as aspirin or an extended release or dipyridamole, whatever it is, or clopidogrel. Okay. You want to review the patient documentation to determine if there's a patient-specific indication noted for all meds in the drug class. All right, so get ready. Here comes a Slido. All right, and there's your code 2174652 for slido.com. You guys get registered in there and rocking and rolling. Yeah, I panicked this morning. I was trying to get out our first vitamin E and my Slido was disabled. I'm like, ah! So I had to get in some technological challenges this morning. So I had to go in and make sure that everything was booted back up, and turns out I had issued the vitamin E before I realized Slido was not working. It was when I went to take a look the next day. I'm like, oh, wait a minute, where's my Slido icon? Up to 35, 36. When I hit 40, I'll probably push it. Everyone's chiming in. Numbers are coming in. Okay, that's good. That'll get us started. Okay, so here's your question for N0415. If the patient is taking aspirin for anticoagulation purposes, it would be checked for code E, anticoagulant. True or false?
Is voting? My
If
thing
voting
says
is
voting is
closed.
already closed.
Oh, no, I opened it. Well, that just bites. All right, so, hey, everyone get yourself on mute. Just chime in. What do you think?
Nope. False.
Nope.
False.
That's false. Good Lord, I'm going to go check that. I don't know why the polling's closed. Goodness gracious. We'll see what happens on the next one. No one participated. Yeah, you guys are slackers. So yeah, that is false, right? If you're taking something for a different use than your drug class, doesn't matter. They're only looking for, do you have that medication in that drug class? And aspirin is not an anticoagulant. Let's try this one, see if the polling's open on this one. Sometimes it might just be that particular question's closed down. The patient's documentation indicates they're taking oxycodone for pain. Tramadol is also listed, but there is no indication documented for the tramadol. In order to check N0415 column 2 opioid, indications for use must be present for both meds. Is that true or false? If you can't vote, chime out. So basically, if we have two meds and indications only listed on one of them, can we check off in column 2 that the indication is noted for that particular class? That answer is true. Indications for use must be present for both meds. That is exactly correct. So they could have 4 meds of the same class, but if only one of them is indicated by the provider that they should be taking it, and there's nothing that says from the provider saying they should be taking those other 3 medications in that class, then you have to mark off that indication is not noted in column 2. So that would not be checked. And I envision a lot of clinicians getting this wrong. This? Oh, that's our leaderboard and Julie's fast fingers. Okay. All right. So then we have our usuals, M2001, the drug regimen review. All right. So nothing changed here. Actually, there's nothing changed. The rest of this is all stuff we knew. This was the only new item in section N was that N0415. And well, that's fine because that's a big enough item, right? So you just want to make sure that, all elements of the drug regimen review have to be completed in order to answer yes or NA, they're not taking any medications, that unicorn that everyone gets once a year that I don't have any medication. You're like, oh, let me come kiss you, right? So if all elements of the drug regimen review were not done, then they would have to report a dash, all right, saying that the drug regimen review was not completed. So maybe they didn't run any of the interactions, or God help us, for whatever reason, they didn't even write down the medications. Who knows? But if they didn't do all the elements of the drug regimen review, they cannot say 0, 1, or 9. They would have to report a dash. And just a reminder here, when an RN reviews the med profile for any of the therapies, which apparently is per the COPs, but we all ignore it, Moon 90 must be updated if the medication items were subsequently updated for any reason. So if the medication items had to be updated because of that med profile review, and maybe a call had to be made to the doctor by someone in the office, and teaching had to be done, whether it's over the phone, whatever, and it wasn't done till the next day, then that Moon 90 date has got to be, and of course that information communicated back to the whatever clinician it was that completed that OASIS. So that Moon 90 date can be updated. And this just talks about, what a potentially clinically significant medication issue is. And I think this gets glossed over sometimes. And I just want to drive this point home so we're not picking up stuff that we really shouldn't be. Clinically significant medication issue is one that in the care provider's clinical judgments, that's your nurse, your therapist that's out there, it requires physician notification. All right, so there's some things, and these are all the different things that, they might be looking at: adverse drug reactions or ineffective drug therapy or side effects. Any of these would relate to be a clinically significant issue. Could be, but there's some, we know as clinicians, we're going to go out there, we're going to find some patients that are on Coumadin and aspirin at the same time. You go and run that in your drug interactions, it's going to flag. And darn well, because this patient. If you call the provider, the doctor's going to reach out and try to slap you on the head because he's told you this every time you called in. Yeah, the patient's been doing this for 5 years. We're good. Don't worry about it. So there are some, if you find out that kind of history, where the patient has been on this regimen forever and it's not a problem, that's not clinically significant anymore. It's just not a problem. So again, this is really it's the care provider's clinical judgment whether or not something is a clinical, whether it's clinically significant. No issues found basically means, all these items here, we didn't find any problems, So they have all their medications they're supposed to have. The list of discharge meds matches what they're taking in the home. The diagnoses or symptoms that they're taking the meds for are adequately controlled. They have a plan for safely taking their medication at the right time. And they're not showing any signs or symptoms indicative of adverse drug reactions. So that's all good. That's your 0. So therefore, code 1, yes, issues were found means something of that above there was not met. Right? So, something is going a little squirrely. And this just, stuff about clinically significant. You can go back and look at it later if you really want further examples. I'm not going to go through it all because you're all perfectly capable of reading. You have the slides. Like I said, everything is loaded up into Easy LMS, and just the slide itself without sound, of course, is in Smartsheet right now. So you can go and see, if you're struggling with these a little bit, you can go and see exactly what these examples are. 2003 follows up. So did the agency contact a provider by midnight of the next calendar day and complete? So it's 2 steps. Did they make the contact and did they complete the prescribed or recommended actions in response to the identified potential clinically significant medication issues? So that means they have to get hold of the provider, actually speak to them or make contact with them in some way that they will get a response back. And if it's something they have to do something about, they have to have that all completed by midnight of the next day in order to say yes. Now, sometimes we know that, especially, if you're a clinician, you're trying to call the provider on the weekend, good luck with that. Rarely happens that you're going to get them, and you're going to get the on-call doctor that says, I don't know this patient. Have them call their provider on Monday. You know what? That is their response back. You really cannot do anything about that as a clinician. So your response back, for this is going to be, yes, we did contact the provider, and the actions that we're completing are to notify the patient that we're going to have to call the provider on Monday. We have been pushed down the walk. So the clinician, they can say yes to that situation. And of course, if someone has to wait, if I'm contacting the provider, I'm out here doing my start of care today, and he calls me back tomorrow, and I take care of whatever it is he tells me to do tomorrow, changes my Moon 90 date. So watch for those that say, yeah, there's a problem. Look at the documentation. Is the Moon 90 date pushed? Or did they actually get everything done that day? Could happen. Could happen. Sometimes you actually call the provider when you're doing the start of care and you get someone on the phone and you're like, oh, yeah, no, tell the patient to do this. And you're sitting there and you tell the patient to do that. Hey, you are done. It's right there on that day. A lot of times you got to keep calling and calling, or have someone call in the office, and hopefully you get it done by midnight of the next calendar day. So this is just, med reconciliation, that it's a 2-step process really, and just leaving the provider a voicemail does not count as reconciliation. You have to have a response back and document that something was done about it, or it's all good, we don't have to do anything about it.
So Arlen, wouldn't that be, what about when you do call the doctor and the doctor just doesn't respond? In that case,
well, what do you mean doesn't
answered
respond?
no, correct?
What do you mean doesn't respond? Like doesn't answer you back at all?
Doesn't return your call. You've made a
yeah,
text,
unfortunately,
however.
we have to bear the brunt of their bad behavior.
Right, I know.
And I usually, when I'm teaching this live, I'll usually tell people, if you're a clinician out there in the field and you find something that you feel is clinically significant, which means there is a problem with the way these medications are or being taken, or the way the patient's responding to the med, whatever it is, you really kind of want to be up that provider's butt about getting a response here. Treat your patients like your family when it comes to med issues, because med issues are basically almost the number one reason why people are going back into the hospitals. Something's going squirrely with the meds, right? So
Right.
if this were your mom and you realize there's something going wrong, are you not going to be calling every half hour until you get a response? You're going to just bug the daylights out of them until they like answer that call, right? So if the clinician, obviously they're in the field, they're just trying to do their jobs. They should like assign someone in the office, say, hey, so-and-so, Miss Manager, can you please keep calling this doctor every half hour and half hour, whatever it takes, get an answer back. Because, it's a medical situation. We're talking
Right.
medications
And
here.
I understand that. And I
Yeah.
mean, I was a clinician in the field for
Right.
a
Right.
dozen
So you
years.
get it. You can't get them.
And
yeah.
when the provider doesn't respond, you have to answer that question as no. Even
As
though
no.
you
Yeah.
did
Like I said,
everything
we have to
within your
bear the
power.
brunt of their bad behavior. Yes.
Okay.
I wish
Okay,
there was a box that said we tried.
I know.
And
I know.
what you should have, as clinicians, CYA, is they should be documenting in that chart what time they're calling, what time they're calling, what time they're calling. So if they ever get audited, they go like, look, we placed 14 calls here. Not our fault. As an agency, we're not dropping the ball. We just can't get, his or her majesty to answer the phone and return a call about their own patient on a clinically significant medication issue, which just blows my mind. But yeah, I mean, I get it. The chance of me, ever actually getting a provider and getting an answer back when I was in the field within that 24-hour window is like almost like hitting the lottery. But yeah, we do have to take the no, unfortunately. If they actually do respond and they give no new orders or instructions, like, yeah, it's fine. We take the yes. We contacted them. They answered back. They say, yeah, there's no action to be taken. That's good enough. All right. So we take the yes on that. So it doesn't have to be that there must be action taken. The action is basically just document that everything's fine and you're good to go. So we take the yes on that. And there's your question about, unfortunately, having to take the no. We didn't receive the communication back until after midnight of that next calendar day, if at all. All right, we got another Slido coming up. It says, oh, get ready. It says, get ready. Let's see if this is an open poll. Should be. There we go. The M2003 yes code requires the provider be notified of the med issue, receive a response back, and complete or attempt to complete corrective actions all by midnight of the next calendar day after discovery. Is that true or false? Water's got warm. More people. Just stalled at 38, 39. Okay, it's definitely ground to a halt there. Okay, so that is true. For yes, all those conditions have to be met. Very good. You got that one. Ooh, way to go, Haley. She was jumping on that one. Okay, M2005, medication intervention. So this one comes up on your transfer and discharge OASIS. All right, so it's basically the same as M2003. So the only difference between this and 2003, because like I said, this only comes up at transfer and discharge, is it's looking at each time ions were identified since the start of care or resumption of care. So it's not just what happened on the OASIS last time, any comprehensive assessment was done, but maybe they got a new medication halfway through. Ooh, now they have a UTI, they're on new meds, and there's been a reaction of some sort. So the provider was notified, and the cycle, goes on and on. So it's looking at any time that an interaction was, any kind of event had to be recorded here since the time of the start of care, resumption care, or which we know means at or since the time of the last start of care, resumption of care. You know, basically the same item, but it's looking at all the times. Now, unfortunately, what that means is if we ever have no's, we do have to carry them through. So if we look at this scenario, we have a clinically significant med. So what I have here is stacked is 2001, 3, and 5. So the first one is a clinically significant med issues identified by the admitting RN at start of care during the drug regimen review. The correct code to M2001 is obviously it's 1, yes. So the RN contacted the MD's office on the day of admission, left a message related to the issue. The physician did not return the call until after midnight the next calendar day. The correct code to M2003 is, of course, no. Now, nothing else has happened during the episode. Everybody's good. At discharge, the assessing clinicians determined there were no further med issues since the start of care. The correct code to M2005, unfortunately, has to stay at that no, because it's looking at anything at or since the time of the prior start of care or resumption of care. So we have to go all the way back to the start of care and where we had to own that no. So yeah, that kind of, you know, ick, but unfortunately that is the rules. We have to just hang on to that no. And 2010 is about patient caregiver high-risk drug education. They're talking about it's targeting just the high-risk meds because it's unrealistic to expect that patient education on all medications occurs on admission. And if they have a lot of high-risk drug education, there could be an issue that you might have to go back and, you know, get another day in there to finish teaching the rest of those high-risk drug meds, because and there's such a importance placed on these high-risk drug meds because that's the ones that, you know, patients can really mess up, and that's the ones can do a lot of damage if they're taking it incorrectly or avoiding taking it or overdosing, whatever it is. So we really want to make sure when it comes to those high-risk drugs that they're doing a good job with taking them correctly. So, you know, we're looking at things like the Coumadins, insulins, opiates, you know, et cetera, et cetera. Yeah, so we're just going to skip on there. So the high risk drug education, you know, so the NA, which is, you know, that patients that are not taking any high risk drugs, or they're fully knowledgeable, or their caregiver is fully knowledgeable. So someone might be coming home on Lovenox, but the caregiver is all over. So yeah, I know everything about this. You know, I've had 2 knees and a hip already done. I know all about Lovenox. So they could be an NA. It's like, yeah, the family, they've got this, not a problem. Now, if education was needed, though, and they didn't get it, so if the education did not include all these following items, they didn't go over all the high-risk drugs before they're trying to lock this OASIS down, or they didn't include any precautions necessary to prevent harm to the patient, or tell the patient what, when, or how to report when any troubles happen, then they're not fulfilling the requirements of this item. So this would have to be a no. And of course, a yes is they obviously then did everything right. So there should be documentation that shows what specific high-risk meds that they did teach on, who did they teach it to, you know, what did they teach about, what was the patient's response to the teaching, did they understand, do they need follow-up? They probably will need follow-up, or just to make sure, you know, on the next visit that they got it, that they understood the indication that they were shaking their head to, you know, on the visit before. Did they really get it, or were they just shaking their head and the minute you were out the door, they're like, what am I supposed to do with this? Happens, right? So, you know, you just want to make sure when you have someone, you're looking at a chart and they said, yeah, all high-risk meds were taught, you know, they checked that yes in M2010, you can't find any documentation about any teaching. That's a comment that really should go back. It's like, hey, you really should have documentation that kind of proves your point here. M2020, and I'll say in M2030, you know, we've had a lot of guidance this year, specifically since it came out in January, about, if the meds are not in the home yet. So when we get to those slides, I might just, discount them all together, but there might be some new people that are sitting there going, what? All right, so we'll just do what we can with it. So M2020, management of oral meds. So this is their oral, they're taking it orally, medications. So, which means it doesn't mean anything you're taking sublingually. So nothing under the tongue, anything that's buccal, inhaled, or per the G tube. So, the milkshake going down the G tube is not an oral medication if there's pills in it. No, it doesn't work that way. So it's got to be taken PO, by mouth. So only those meds placed in the mouth and then swallowed with absorption through the GI system are considered. So the clinician should be looking at the assessment of the patient's ability to obtain the meds from where they're routinely stored. Can they read the label? Can they open the container? Can they select the correct pill or tablets or milliliters of liquid, whatever the situation might be? Can they orally ingest the medication? Are they choking on it like I am here right now? Can they take the medication at the correct time? Do they have a plan to take the medication at the correct time? And can they state if there's any restrictions? I can't take it with certain foods, or I shouldn't take it with my meals, or I should be taking this with my meals. I take this first thing in the morning. I take this late at night. Are they able to state it, and are they stating it correctly? Code 3, the unable option is if the patient did not take any new meds because varying doses worried them, there were unsure of instructions, that kind of person would fit into that code 3 as well. So until education is done or plans can be put in place to maybe get this person out of a 3, score them as that 3. Let them stay down there in that dependent zone there. M2030, basically the same scoring as the oral meds. So this is about the injectables. One-time injections administered in the home are included here. So we are in flu season, right? So if there's any nurses going out there doing the injections, make sure if you see that flu injection was given during the visit, make sure that they check that off in M2030, right? And that's going to be a 3 is how that's going to be scored because they're the one doing the injections, not the patient. Assessment of the patient's ability to obtain the med from where it's routinely stored, draw up the correct dose accurately using an aseptic technique, inject in the appropriate site using the correct technique, and dispose of the syringe properly are all included in the management of your injectable medications. PRN injectables should be included on their plan of care. If it's not needed at the start of care, obviously, we can't make the patient take their insulin now because it's not their time, but they should be able to walk them through the steps. The patient should be able to walk through the steps to show how I do it. Tell me what you do. So it excludes IV meds or infusions and meds given in the physician's office or other settings outside of the home. Yeah, we've talked about these. Okay. So this is that stuff, scenarios with the same code. So all these different situations of, the patient's not fulfilling their medications, or they're not in the home yet, or, they live in an ALF and they can't get to them, or the pharmacy hasn't delivered their meds yet. Before we'd all say, hey, that's a 3. You can't assess what doesn't exist. Well, the CMS scratched its head a little bit and they said, yeah, we don't like how you guys are answering that, probably because we're giving away too many points by scoring everyone a 3. So, of course, outcomes are always going to be great then. So they said, hey, what we want you to do instead is, now, the assessing clinician should rely on their assessment of the complexity of the patient's overall drug regimen, as well as patient characteristics, including their cognitive status, their vision, strength, manual dexterity, general mobility, along with other relevant barriers, and use their clinical judgment to determine the patient's current ability. So basically they're saying, okay, pretend that if that medication is there in the house right now and it's in front of them, how would the patient do with taking this medication properly? So that's how that item is now supposed to be assessed. So there should be a lot more people coming off of that code 3. Whether that's not that's actually happening? I don't think so, because I've been looking at a lot of charts lately and I see that code 3 is still a lot, and I think a lot of them aren't valid, but it's not a money item, so it's an outcomes, but it's not a money item, so there's just not that level of oversight coming in yet. And again, this is about the ALF. So, some places their meds are locked up, or if they're in a home, the patient's daughter has moved their meds out of the grandchildren's reach, which unfortunately also put it out of grandma's reach. So how do you score that? And they say, again, if the meds were there and available, placed in front of them, how would they do with that? Now, that is not the same as saying my meds are within reach. I have to walk to where my meds are, and then I can access them. They're in the kitchen. I have to walk there. I am not safe ambulating by myself. I could still be scored a 3 under those conditions. It's when you're hiding them from me that things change a little. So if there's still that access issue, that's code 3 is still going to come into play when it comes to access because of our ambulation. All right. And that is everything. I'm going to stop sharing here so I can open up my screen. All right. So any questions at all?
We had a question on NO415. I think that's the high risk med.
Yeah, that's the
question.
new one. Oh, okay.
What's the time frame for this item? For example, the clinician gets med reconciliation done, contacts provider same day, and gets indication for the other 2 antibiotics the patient's taken. Do we now check the box for indication noted? Are we still working in our 5-day window on that?
I'm thinking about the example you gave, Arlen.
Yeah, I
when you
know.
were
I'm
reviewing that
thinking.
item.
I'm trying to think if there's any guidance on that. I think what they're going to do, if I were to send this into the CMS help desk, they're probably going to come back and say it's a day of assessment item, which means you have to answer it based on the day of assessment.
Okay.
I will send it in though. It's a good question. I will send it in. I will get back to everyone on that with
I'm
either
curious,
a thumbs
why do
up
you
or thumbs
think-
down.
Why do you think it's just going to be day of assessment?
Because most of it is, if there's basically the way the OASIS goes, if there's no other time frame shown in the item, it's a day of assessment item.
Right. Okay, I got you. I'm with you now.
Yeah.
I wasn't thinking.
That's my only. I'm just going to immediately default to that, but it's a really good question, so I am going to get that confirmed. And they, unlike the coding center, the help desk gets back really quick. So that's a really good question.
And what did we decide on research that are done late December and start in January?
Yeah, well, what we decided, well, it's not like we decided anything. So the question came in, does it seem weird to anybody except for me and April and Janan, because I brought her into this conversation as well, that we do a research, let's say December 27th, you do the research, or December 28th, whatever. But the cert period actually begins January 1. But because your Moon 90 date is in 2022, you're filing a D1, which is weird because your cert period starts in an E episode. Well, you know what? None of it goes to payment, so it really doesn't matter. Is it weird? Yes. But that's the way they do it. They hang their hat on Moon 90. So it'll just get caught the next time this patient either resumption care or research, then it'll flip over to an E version. But yeah, it's just weird. But like I said, there's no payment hanging on any of it, so it's not really an issue. And that's the thing, because the payment is just those M18 items in M1033, which is the exact same in both versions, so it really doesn't matter.
I think the biggest thing, I was just thinking about this when you were talking, that we have seen over time when they change versions is invariably we're going to run into some OASIS that are done on the wrong version and have to go back to the agency and say, this needed to be on whichever one.
Yeah, well, shame on their EMR for allowing it to even, go through, but, it's better that we catch them than they try and submit and find that it can't.
Right. I know
They're
Wellsky in the
they're
past
gonna
has
get
let them go
stopped,
through.
so, yeah. Let's be the first boomerang instead of the one when they're trying to submit, 30 days later for money and no, you can't. So just comes back in their face. Do antidepressant meds fall under antipsychotic? For example, taking trazodone for insomnia. I'd have to look up. I don't know the high risk meds off the top of my head. I'd have to see that.
You just need to
tool that
look
I'm
up.
sending
I think we
out.
just need to look up the drug class, won't we?
Yeah, you just have to look up the drug class. A lot of the EMRs, they have it. Not all are published to their clients. There might be like an add-on pay. I think I'm hoping to hear / see when, the E's roll around that they are all included. So clinicians aren't like having to Google up everything, and see what they are. But we will have in the tool that we have, it's a searchable item that you can just type in tramadol or trazodone and see where, if it pops anywhere. Or you can do it by class just to see, like right now you're thinking, is it antipsychotic? Is trazodone on the list? If it's not, then it's not. Yeah, I don't know what the drug classification is for trazodone. I know I take it for sleep, so I honestly don't know what its drug classification is. I don't care. It works. That's all that matters to me. It's not addictive, so even better. But I will get back to everyone on Pam's most excellent question. Any other questions? Yeah, but that's looks like an antidepressant. Okay, so it's not an antipsychotic then. Yeah. I don't think all the antidepressants fall under antipsychotics. They would have to be, I mean, these antipsychotics are some, we're talking the Haldols and things like that. They're, serious stuff. And you'll see that next Tuesday when I issue it. Actually, I have your listing. Do I have it? I should have the list of all these people that are on this. So maybe I'll just drop that. What I don't want to do is drop the tool too early and then have a bunch of people that haven't had any training at all go, what on earth is this? That's why I was going to wait till next Tuesday. Yeah, you guys just chill till next Tuesday with the meds. You don't need it till December 27th, theoretically. Hopefully we won't have to do too much looking at all, but like I said, I'm hoping that the EMRs catch it all and give the clinicians the assist they need on that. Any other questions? All righty. Well, next week is going to be the last week. Yay. It's section O, as I call it. It has basically like one new item and then what, M2200 and M2401. So, nothing new there, but that one new item is a big one. So that's why I call it section O. It's a section that makes me glad that I'm not in the field anymore. All right. When will the OASIS test be available to take? After next Thursday's class. And, don't think of it so much as a test, but it's more of a, self-assessment. Look to see where you stand in your retention of any of this. And that's why I'm sending out the daily vitamin E, because, many have expressed that, we've been spread out over this time frame and there's just a lot of new stuff to absorb, stuff we've never seen before. And they feel like they've lost some of it. So sending out those dailies, just get them back in front of your face again. And, no one's going to lose their job over this. It's just to see, where you stand. Maybe you need a little to read up again on some sections. There's just 40 items. Everything is taken from this class. It's not like I secretly dug up stuff from somewhere else. So it's all the stuff we've gone over. So it is not a timed test. Take it as many times as you want. It's like I said, no one's going to get fired over this. It's really more of a self-assessment, so you can see where you stand in, oh, clearly I need to look at section blah, blah, blah again, and whatever. But we just need to know that everyone is up on this as much as they can be, because we're the experts, so we've got to be on top of this when it goes live on the 27th.
The question's
OASIS
coming back in, which you talked about the other day about the Moon 90 date.
Yes.
The Moon 90 date of 1/1 or later. So
Right.
if it's a start of care, sorry, Arlen, I just jacked
Yeah.
your
No, it's all right.
presentation.
I think we're both reading the chat at the exact same time. Yeah. So keep going.
So if they did a start of care, say on December 28th, but then my PT or my OT doesn't go out to 1/1 or 1/2, and I use that information to update my OASIS, thus updating my Moon 90 date, even though the nurse went out on 12/28, my Moon 90 date is going to be 1/1 or 1/2, depending on when they went. So I would use an OASIS E version. It's crazy to me why you don't use that start of care date, start of episode date, whatever it is, but they don't call and ask me, unfortunately.
Right. Yeah, exactly. And trust me when I say from December 27th through the 30th and the 1st, I will be hitting up a daily keep your eyes open for. So yeah, I'm not going to let that one just, hey, do you remember what we said at the December 1st? No, I don't remember. I don't expect anyone to remember anything because frankly, I can't. So, it's just too much. So I will be peppering email that whole entire week. So it'll just keep coming right back in front of you. Even have a little chart you could probably print out if you want to, or send off to your agencies if they're just not getting it. It's like, what do you mean I have to change your OASIS? I'm sorry, you have to change your OASIS. Yeah, go ahead, try and submit that. It's coming back. It's going to be denied. So yes, it's all about Moon 90. All right. I don't see any other new kind of questions. All right. So with that, I will say have a great weekend.
Thank you, Arlen.
Yeah. Thank you. You can stop recording.
Mm-hmm.
Mm-hmm.